Sorry. Okay. So the only approved checkpoint therapies right now are for PD-1 and CTLA-4 pathways. There are many different agents are approved for different cancers. So there's only one CTLA-4 drug. There may be two. I think AstraZeneca has another one. So Yervoy. There's lots of PD-1 drugs, Optdivo, Keytruda. This other one that I don't know about, but it's under development. There's 3 PD-L1 drugs, Imfinzi, whatever these are. I don't know where they come up with these names, but anyway. So that's what's out there that are approved, and you can be treated. Your oncologist can prescribe these therapies. Again, these can be Yervoy can be used in combination with these other ones. There is, in certain situations, benefit, but there's a lot more toxicity associated with that. Again, these checkpoints are not approved in cancer, in prostate cancer, but there are many trials underway, mostly in the metastatic RPC setting. And these trials include new combinations of therapies, which I'll talk about in a minute. So what are the limitations of checkpoint inhibitors? So if they're so great, why don't they work all the time? Number one, you must have an existing T-cell response even if it is suppressed. And in some cancers, in some patients, you can't find any T-cells. The CTLA-4 and PD-1 can induce severe side effects that can force patients off treatment. These typically resemble autoimmune diseases and can be quite severe. However, in most cases, the condition is manageable and transient. But when you do the two together, it's really, really tough. So as many as half of patients don't respond. So you can look at that 2 ways. They were all terminal, but so we can look at this as being the cup half full. But that's not cure, that's just a response. Tumors shrink at least for a while, and we need to do better. There are many mechanisms of failure which vary from patient to patient. Antigen loss, so let's say the T cell is targeting a particular mutation on the surface of a cancer cell. We already said, well, what if you mutate the MHC? You won't see the antigen, but it can also stop making that mutant protein entirely. That's called antigen loss. There can also be additional inhibitory proteins. So even though you're blocking the PD-1 pathway and the CTLA-4 pathway, there are other inhibitory pathways or proteins present. Again, for example, TGF-beta, but there are lots of others. That prevent, even if you fix this, you can't fix these. You're not fixing those. So here's the trial that's ongoing. I heard this summary at the beginning of March this year. It's the CheckMate 650 clinical trial. It's Yervoy, CTLA-4 and PD-1 in prostate cancer. So they started with 2 groups of patients. They had 32 patients that had received androgen ablation. This is enzalutamide or any of the other number of drugs. And a second group that had received, same size, that had received androgen ablation followed by chemotherapy. So when the androgen ablation stops working, you move on typically to chemotherapy. In the first group that had only received androgen ablation, they had 25% of patients that showed objective responses, 2 of which were complete responses. And that means by a scan they can't see any disease. That doesn't mean there isn't microscopic disease. So that's not the 50% that you see in melanoma, but 25% is 25%. It's not so cold that nothing happens. In group 2, they saw only a 10% response, 3 out of 30 patients. But they did all 2 of those 3 were complete responders. And in general, the responses were better with soft tissue disease, liver mets or whatever, than with bony metastases. Again, in bone metastases, the bone is degraded, that releases TGF-beta, and that inhibits T cells. I'm sorry to keep mentioning this, but we're really excited about it. So it's hard for me to not talk about it. Anyway, but again, toxicity with this dual checkpoint PD-1 and CTLA-4 was severe. Grades 3 to 5 in half the patients, and 4 people died on the trial.
When you say grade 3 to 5, what's the scale?
Well, it's 1 to 5. 1 and 2 don't count, but you have to report the 3 to 5 to the FDA. 5 is death.
Is there a grade higher than 5?
No. Okay. You can't get worse than dead. So the so anyway, that you report these toxicities in grade 1, 2, grade 3, grade 4, grade 5, and typically if you have grade 4s and 5s, the FDA pays attention, and that becomes a problem in getting approval, and you have to either show that you can mitigate that, or in some patients, if there's no other, I don't know how the FDA makes that decision, that you can, if you have a patient that has no other hope and wants to take the chance, can you still give them this even though there's this risk of a grade 5? But I think they're already trying to address this in the trial. So again, although prostate is a cold tumor in general and not expected to respond, 11 of 62 patients, or 18%, had an objective response. And they're going to continue to follow these patients because this trial is just ongoing. This is like year 2 of the trial. So we'll see how these patients do and how durable their responses are, how long they last. I think one take-home lesson from this is if you're going to get checkpoint therapy, checkpoint blockade, it's better to do it before you start chemo. So chemo kills dividing cells, and immune cells are constantly dividing. So when you have long-term chronic chemo, 6-month chemo, whatever they do, you don't have much of an immune system left. It's knocked way, way down and tends not to rebound very well. So expecting immunotherapy to work after it doesn't mean it won't work, because you saw there were 3 responses. But if you're at that point where you're on enzalutamide and your PSA is rising and you're trying to decide what to do, if you're able to get into a clinical trial, that's what I would do before I would go on chemo. Because trying to do immunotherapy after chemo is going to lower your chances, I think. I'm not an oncologist. I'm not a medical doctor. This is just my own personal opinion.
What's the
Again, go ahead. Go ahead.
What is the typical length of therapy for these treatments?
Pardon?
Let me repeat that, Nick. He was asking if you're going to get immunotherapy, what does it look like? How many doses for how long do you get it?
So you get it in cycles. I think it's the cycles vary. I think it's every 2 weeks, and it can go on for up to a year.
Thank you.
I'm not. I mean, that part I don't, because I don't ever do this therapy. Deliver it. I don't. I think it's if you go to the CheckMate 650, the scheme on the clinicaltrials.gov. It'll say what the dosing regimen was.
Right. I've also heard, Nick, 6 months to a year, a dose every 2 weeks for 6 months is
yes.
Told, but
that sounds right.
Year. Yeah.
Okay.
That's a good question.
Pardon?
Well, there's an FDA-approved drug called Provenge, which has been around for quite a long time. I think about 10 years, I think, where they take they take your dendritic cells. They take out of your blood. They educate them, and then they inject them back into your body. And these are dendritic cells.
Yes.
They have some effect against prostate cancer. That's what Mike was asking about.
Oh, okay. Yeah. I pretty much didn't talk about Provenge, partly because it didn't work very well. It's still prescribed. The average benefit was 4 months and cost $100,000. So a lot of patients object to it. It's somewhat controversial. I know I've heard or read somewhere that there's discussions in Medicare whether they will continue to pay for it. I'm going to have a little slide on vaccines, and I'll talk a little bit about Provenge. But it is an immunotherapy, and I'll talk a little bit about how that vaccine type therapy works in a very, very brief way. Some slides down. So, given the toxicity and the limited response rate, there was a comment on this trial made that I read by Dr. Anton Arakis, who's someone that Eitan has talked to, but he made the remark that given the toxicities, that there ought to be a way to screen for patients that are likely to respond. Again, they're trying to get away from these by changing dose levels and dose schedule to see if they can avoid the more severe side effects. But that could be just a little hand waving that they're saying now because they don't really know what, if anything, is going to work. But this is not only true in prostate cancer. In all these checkpoints, you could save patients a lot of pain and suffering and save a ton of money if you knew who was going to respond ahead of time. But that's true of a lot of these therapies. And so I think we're all working on that. The whole field is trying to figure out how we can identify which patients are surviving, who would survive, which would benefit from this therapy. So the Pam Sharma at MD Anderson, who did this CheckMate 650 trial, they analyzed all of their patients and tried to distinguish responders from non-responders. So what they found is what you would expect: higher tumor mutational burden in the responders, greater than 75 mutations detected in the tumor. Higher PD-L1 in the tumor, that is more PD-L1 expression by the tumor cells. And then if there were mutations in DNA damage repair and homologous recombination repair, which these are enzymes that help keep the DNA, the genetic information intact. If you have mutations in there, that tends to lead to more mutations. It's this paradox that more mutations can get you in trouble in getting cancer, but more mutations can also give more targets to the immune system so that you have a better chance of being treated for the cancer. And so it's possible to screen patients, but this is a tough one because, yeah, there's a high probability if you have greater than 75 mutations, but it only takes one good mutation. You could have 5 mutations and one of them's good and you could benefit. And if they exclude you because of that, you wouldn't get a chance at the therapy. So that's a tough, from a treatment point of view, it's a tough choice to make. And I don't think they exclude patients yet based on that. They do on this basis. Typically, they look at your PD-L1 score. And interestingly, right now, any cancer can be treated with checkpoint therapy if you have mutations in a disease that these leads to higher mutations. So they don't care if you have counted the mutations. You can get treated. That may be a little bit overgeneralization, but more cancers are being opened up to checkpoint therapy based on seeing these kinds of mutations in DNA repair. So what you see in clinical trials now is a whole bunch of combinations with enzalutamide. So one of the things I haven't told you is that as cancer cells die, they become more immunogenic. And that cell death stimulates the immune system. The other interesting thing is that when you're on androgen ablation, you get new T cells. So your thymus is making T cells when you're young, but starting at around age 20, it slowly shrivels up, and this is testosterone dependent. So by the time you're in your 50s, the output of new T cells, and these T cells with new specificities, new target potential, you're just not getting any. When you go on androgen ablation, your thymus wakes up and starts making new T cells. So I think this is a great strategy. I don't know that it'll make a difference, but from a strictly logical point of view, this should potentially be a good combination.
So
They're also combining. Go ahead.
Can I stop you there? So you're saying that actually androgen ablation can stimulate production of T cells?
Yes, by the thymus.
Really?
So that's the organ where new T cells come from.
Huh.
And you lose that, both men and women lose it over time. In men, it's testosterone driven. So that when you go on androgen ablation, you get reactivation of the thymus, and it starts to deliver more new T cells to the body.
Okay.
There's also combinations of checkpoints with these PARP inhibitors. Again, these are inhibitors of DNA repair enzymes, and they also induce cancer cell death. As you recall, at some point, if you overload the cancer cell with mutations, it's going to kill itself, because there's certain genes it just needs, and it's already probably missing some DNA repairs. If you block even more with inhibitors, you can basically drive this thing over the edge, and it dies. And that cell death is also immunogenic. And these things also, I should point out, both of these, and these as well as reduce tumor burden. So the ability of your immune system to clear a cancer is partly a numbers game. The more tumor cells you have, the bigger the job. So if you can reduce the tumor burden by any of these mechanisms, surgery, radiation, enzalutamide, PARP inhibitors, whatever you're doing, that gives the stimulated immune system a better chance at curing the cancer. And then they're also combining these checkpoint inhibitors with vaccination. And I think I had a slide about vaccination. Maybe it's at the end, or let me look ahead. Let's see. For some reason, it's not responding to my button pushes, which I don't know why. All right, well, I'm going to go on here. I think I'm going to come back to vaccination later. So there's just one slide on this therapy, which I think has lots of potential. It's called adoptive cell therapy. You expand T cells from the tumor in culture, in an incubator, and then you give them back to the patient. So you perform surgery to remove the tumor. You isolate the T cells from the tumor. Use both physical and enzymatic methods. You grow the T cells in culture, in an incubator, by stimulating them to divide. You can expand these to 500 million to 1 billion cells. And then you use chemotherapy agents to deplete the T cells in the patient. So again, you're giving one round to just lower the number of T cells, and that creates space. That is, in your body, there are lots of chemicals in the blood that keep T cells happy because they're long-lived, they're traveling around for a long time, and they need these factors, these growth factors and other things to keep going. So if you're going to dump in 1 billion other cells, they'll be competing with the existing T cells for those factors that make them function well. So you knock down the existing T cells. You don't lose any of the kinds of T cells, you just lose the numbers. So, and then you put in these T cells. The infused cells are you infuse them back into the patient, and this technique has worked pretty well in melanoma, but has not been tried in prostate cancer patients. So there's lots of work. We're doing a lot of work in this area at our institute, and we've actually, there's two new, which I don't think there's time to talk about, but there's two new developments in this therapy that have the potential to make it work much better. There's always the question of whether these are targeting the same cells as the checkpoint, the same patients as the checkpoint inhibitors. But it turns out there's overlap, that there are patients that fail in melanoma, that failed PD-1, but then were cured with the adoptive cell transfer. Again, how would you know? It would be nice to know which therapy to give a patient beforehand, but we haven't got there yet.
So Nick, if I can stop you here, so the point of this one is that there's T cells in the tumor microenvironment, whatever you call it,
yes,
already have recognized the cancer cells, but not,
right, because that's what we got there.
you're just multiplying them by a great deal to make them more effective. And so if you have systemic disease, then you inject these T cells into the bloodstream, and they would be send out cancer cells wherever they are in the body. Is that the idea?
Correct.
Okay.
Correct. I mean, I saw this therapy has been going on for about 30 years, actually, mostly in melanoma. Dr. Rosenberg at the surgery branch at the NIH has been doing this for many years, and he'll show you a scan of a patient with tumors virtually all over his body, brain mets, liver mets, everywhere. And they did this therapy, and they're gone.
Regarding
I'm sorry. So again, there's the issue here about the number of mutations that's presented on the surface of the tumor cells. Are you saying that could be less of a factor here? So more kinds of prostate cancer cells might be affected by this particular therapy?
Yes. Well, you're reactivating a T-cell response.
Okay.
But you're doing it away from the suppressive environment of the tumor. So you're doing it in a lab, and you're sort of improving the numbers, right? So instead of the few cells that are left in the tumor, you're now giving them billions back. So you've evened the odds a little bit by giving this large load, and you're giving them all the different T cells that reacted to the tumor. Right. Now, that doesn't mean that 99% of the tumor will go away, but there's a couple of cells somewhere that actually don't have those mutations anymore. I mean, they're not making those proteins anymore.
Right.
Or that have mutated the MHC and aren't displaying those mutations anymore. It has the same failure mechanism as all the other immunotherapies, but it's just a different approach.
Yeah.
With respect to the first point where it says perform surgery to remove the tumor, in the case of prostate cancer, would that require a full prostatectomy, or would a biopsy yield sufficient samples to grow the culture?
There would be plenty of cells to do that by removing the prostate. I don't know how much tissue you need. You can actually start with a few thousand cells, so it doesn't take a lot at the beginning. But I don't know whether someone who still has a prostate, if they have the prostate plus they have disseminated disease. I mean, normally you would go to I have to think about this because I'm not a
And if the
oncologist. But I think yes, to answer your question, there would be enough cells. I don't know if you'd need just a portion of the tumor or the whole prostate to get enough cells. I don't have the answer to that question. I don't think normally when people operate on prostates, they just take it. They're not taking part of it. And if you're going in there using lasers or whatever, you're going to kill all the cells, the T cells anyway. So typically, this is being done in melanoma, where you're taking a metastatic deposit, surgically removing it and getting the T cells. In colon cancer, you can go either the primary tumor or metastatic disease and harvest cells from there. It's generally, if there's an easily available place where you can get tumors, that's where you go, because it's a surgical procedure. We see a lot of these because we're doing a lot of analyses, because we're in a hospital that's doing surgeries on tumors all the time. So we develop all these protocols based on getting these piece of the tumor from the surgery, and they're pretty small sometimes. There's maybe less than a cubic centimeter or half a cubic centimeter of tissue, and we can get millions of cells out of there. So
I think lymph nodes might be a good target, right? So for prostate cancer, typically, if there's progression, it goes from the prostate to the lymph nodes and then to the rest of the body, and they're often infected lymph nodes. That might
sure, absolutely. If there's a draining lymph node that has cancer cells in it, that is a good place, because you're likely to have lots of T cells that are recognizing that tumor, because the lymph node is where a lot of the work gets done. So yeah, you would, haven't really thought about, what would you do with prostate cancer different, because right now we're getting lots of different cancers, but none come from a small organ like prostate. We're doing liver mets and colon cancer and lung cancer and head and neck cancer and melanoma and all these different cancers. We've processed, maybe 8 or 9 different histologies, different types of cancer. So I'd have to think about, I can actually talk to some of the guys here and say, well, if you were treating a prostate cancer, where would you look for the cell development cells? But a lot depends on where you are in the disease, right? Because, radiation and, if you're a Gleason, I was a Gleason 7, 4+3, I'm not sure that they would work up cells for me, because I have a chance of just being cured by the procedure. So, it's very expensive to do this when it may not be necessary. So it has to be a patient where you actually know the tumors escaped, and then the question is, where's the best place to get a piece of the tumor so you can get the T cells? And I think that I think hasn't been worked out, at least in prostate cancer. So, I don't know why. So another new thing that you may have heard about, is there a question? Okay. So for some reason my slides aren't advancing. I have to hit the button 3 or 4 times, so please excuse me, and I hope I don't curse under my breath. Anyway, so CAR-T cell therapy. So this is a new therapy that's just been approved or being approved in blood cancers and lymphoma. It's pretty exciting, and there are trials now in prostate cancer using this technology. So I'll take you through. Oh, I went the wrong way. Okay. So what does CAR stand for? CAR stands for chimeric antigen receptor. So many of you probably know chimera is a mythological beast. I think the Greeks get credit for this one. It has a lion's head, or maybe not, a goat's body and a snake's tail. So in this setting, it describes a fusion protein that's a gene that's part of one protein and part of another protein. So in this case, we use genetic engineering to combine the T cell receptor and an antibody. So here's the TCR. Here's an antibody. They're always represented as a Y-shaped structure because they sort of look like this. And in this case, we'll call this PSMA, which is a prostate-specific membrane antigen. So it's a protein made by prostate cells, and it sits on the surface of prostate cells. And here's an antibody that binds tightly to PSMA. So what you want to do is to redirect the target of the T cell to the antigen you want it to see. So normally what we have is the TCR recognizes the MHC, gets excited, kills the prostate cell, prostate tumor cell. In CAR-T cell therapy, we take off this part of the gene and we add to it the antigen recognition part, the part that recognizes PSMA, and we stick that on the end here to make this structure. Interaction via this mechanism works exactly the same way in terms of what the T cell does as this mechanism. So here, the antibody portion of the TCR binds to PSMA. That activates this T cell, and it kills the tumor cell exactly the same way here. So does that make sense?
So, Nick, is the point being that there's more expression of PSMA on the surface of prostate cancer cells, and therefore there's a greater chance that the CAR-T cell will be effective? Is that the whole point here?
Well, there's a couple of points. Number one, you're independent of MHC.
I'm sorry.
So all the things that can go wrong with antigen presentation aren't relevant here.
Mm.
So, what you need is a protein that's not expressed anywhere else. So it works well in blood cancers because there are certain proteins on the surface of blood of certain kinds of blood cells that are only expressed in those blood cells and aren't present anywhere else. Because when you treat this with this CAR, you're not only going to kill the cancer cells expressing PSMA, you're going to kill any cell, including all the normal prostate cells that are expressing PSMA. So let me see what else I have here. So here's my vaccine thing that's out of place.
Okay. So
I'm going to have to. Oh, go ahead.
Expand on this a little bit, because CAR-T cells have gotten a lot of press, and I understand they also have some pretty severe toxicities, or can have some pretty severe toxicities. But what you're saying, I think what you're trying to say is that by making them very specific for cells that express PSMA, you're going to reduce toxicity or make them more effective. Is that the idea?
Well, part of the problem is they can work too well.
Mm.
You can get a thing called cytokine storm.
Yes.
And they're working on that. But sometimes these T cells divide too fast and they get too active. And they're releasing, especially in these blood cancers, they're releasing all these things in the blood, which then affect the whole body. And so, I think they've solved that problem in lymphoma because they're getting approval for that therapy. So the problem is no one's tried it in solid cancers, lung cancer, melanoma, because you can't find any proteins that aren't expressed in normal tissues. You obviously don't want to target a protein that's also expressed in the liver because you're going to lose your liver.
Right.
But the good thing about prostate cancer is it actually has 4 or 5 proteins that pretty much are expressed only in the prostate, and if they're expressed elsewhere, it's at very low levels. So you get a side effect, but it's a manageable side effect. So I'm actually quite excited to see if they can make this work. It's a challenge, but I think that it's an exciting time to see how this is going to work. So I managed to get one of my slides out of order, so I'm going to go on with this part and come back to that vaccine.
So Nick, we're about to run out of time. Could you, I know you got about 10 slides to go, I think. Could you wrap it up in about 10 or 15 minutes?
Yeah, I think so.
Okay.
I'll skip the vaccines for now.
Yeah.
Maybe we can do that another time.
Sure, we can add it on later or something.
Yeah. At least the slide will be there in your posted slide deck, so people want to look at it, they can. So again, the antibody is used for recognition of a specific normal protein on the cell surface that triggers the TCR signaling and destruction of the target cell. But again, you need a protein that's found only on the target tissue, so normal and cancer, and not anywhere else, or off-target cells or tissues will be affected. That was what I just said. CAR-T cells have been used very successfully in blood cancers, blah, blah, blah. We said all this. And it's much harder to find a unique, again, it has to be a cell surface protein on solid tumors. And again, you can have a lot of fairly unique proteins like PSMA, PSCA, there's prostate acid phosphatase, PAP, and of course, we can live without our prostates, at least I am. So it's something that you don't have to worry about hurting an essential organ. So here's a set of trials that have happened. They go back as far as 2010, but these didn't work. But they didn't know how to make CAR-T cells. The engineering has gotten much better. I'm pretty excited about these two trials. I heard Dr. Carl June talk about this trial. I'll give you a little, one slide of data. But these are using, in this case, they're targeting PSCA, which is prostate stem cell antigen. And this one's using PSMA as the target. But it's the same CAR-T cell. And the interesting thing is both of these have done a trick to these cells to engineer them to be insensitive to TGF-beta. Because they know that TGF-beta is going to be in the prostate tumor when the cells get there. So they've arranged it so that TGF-beta receptor is not functioning on the T cells. So I'm hopeful. I guess I should leave it at that. So there was one, and I'll go this quick. Oh, so this is the rationale for why you're going to do this CAR-T cell therapy in prostate cancer. So this is preclinical models. So we do all this thing in mice, all these experiments in mice first. So we have a human tumor cell line called PC3. So these are human tumor cells. And they have some that make PSMA and some that don't make PSMA. So there's two different plots. One plot has ones that make PSMA and the other plot don't make PSMA. And then we have mice that have no immune system. So they're genetically engineered that you can grow human tumor cells and T cells in the mice without the mouse immune system attacking them. So what they did is they implanted the tumor. On the right flank is the PSMA tumor. On the left flank is the tumor without PSMA. This is what it looked like at the beginning. 35 days later, it's grown. And what they also did is they took T cells from a prostate cancer patient, and they delivered those to the mouse. So the patient's T cells with the PSMA positive or negative tumor, and you look after 35 days and both of them have grown, so they're the same size. So the T cells didn't impact the growth of either the PSMA positive or the PSMA negative. However, if you give them these CAR-T cells that are resistant to TGF-beta, you can see that the tumor that expresses PSMA is almost gone at the 35-day mark, whereas the PSMA negative tumor is untouched and continues to grow. So based on this, they went ahead and did the clinical trial. This is the clinical trial. I'm going to skip this. The one that's interesting to talk about is that if you give, they try to dose thing, and not much happened here because they didn't do the lymphodepletion. When they did the lymphodepletion, that is to make space, and they only had talked about patient 1. So I don't know how well this thing did, but we did get some data on patient 1. This person had bone-only disease and a rising PSA. He was at 40 nanograms per mil. He had had abiraterone, he'd had Provenge, and then he had abiraterone again. And this patient's PSA was at 0 on day 19 after treatment. So, you know, they have to do all the rest of the patients in cohort 3, and then we have to wait a long time to see what happens. But it's pretty exciting. And the last thing, is there time for this last slide? Should I continue, or do you want me to stop?
All right, go ahead. That's fine.
Okay. Eitan sent me this link to this trial, which I think is a pretty interesting and clever way of attacking cancer. So basically borrowing from cold sore therapy. So cold sore is caused by herpes infection, and when you get a cold sore, there's stuff you can rub on. It's called cyclovir. And this cyclovir is made in 2 forms, procyclovir and cyclovir. So cyclovir can kill cells. Procyclovir does not kill. So it's killing the cells that harbor the virus. So when you treat a cold sore with this procyclovir, the herpes virus has an enzyme called TK, N-scopolamine kinase, but it's a TK, that converts procyclovir to cyclovir, and the infected cell dies. However, when the procyclovir gets into normal cells, it does not have this enzyme, and so the normal cells aren't harmed. So what they did is they made a virus called adenovirus that contains a gene for the herpes thymidine kinase gene, this TK gene, and they call that virus Prostatak. They injected the prostate with the virus, and the prostate cancer cells are infected, although it's not exclusive to the cancer cells. But and then you give the patient orally procyclovir. So throughout the body, procyclovir does nothing, but wherever cells in the prostate are infected by the virus, those cells die. Typically, cancer cells are more easily infected than normal cells, but you're going to hit both. The presence of the viral proteins in DNA and the dead and dying tumor cells are highly stimulatory. These are huge danger signals. And so you can take the tumor where there's not much signals to push the immune system and turn it into one where it's getting these big danger signals. And this tends to recruit these tumor-specific T cells to the tumor. This study is in phase 3, which means you have to see a good signal in phase 2 to get to phase 3. They're treating high-risk patients with local disease. They're giving radiation plus this Prostatak vaccine. There's another another trial here that I don't know too much about. But I think it's going to be interesting to see. The problem is these trials take a long time because prostate cancer tends to be slow. We tend to live a long time, so the trial has to go out many, several years to see if there's going to be an impact, especially when you're looking at these high-risk patients. And the goal is to lower the risk of recurrence. And that's one thing I like about this trial is because you're not waiting till the CPRC stage to treat patients. It's clearly an immunologic response. So you're giving the virus, but ultimately it's the immune system which kills the rest of the cancer. And that it's targeting a much earlier stage in disease, and it's something that one can look at before you do this, before you get to this late stage. And I guess I would just summarize by saying, there's lots of interest in clinical trials for immunotherapy prostate cancer. So even if you're not hearing about it in the news, there's a lot going on in clinical trials. And again, there's many different approaches and combinations to be tried. There's an overwhelming number of combinations of 2 or 3 or 4 things to do together, what order to give them, what doses to give them. It's going to take a while to, unless you're lucky, to figure out how best to treat, to make these combinations work. But it's in the process. Again, it's a complex problem, so immunotherapy will not necessarily work for everyone. Remember, cancer is a moving target. It's changing all the time. That's how it escapes conventional therapies. In immunotherapy, the immune system is adaptable, but eventually even it can't keep up. So this is a really difficult disease to treat. The goal on the end is to tailor the therapy to the individual patient. This means identifying all the somatic mutations, all the mutations that are occurring in the tumor itself. There are ways to target individual mutations. There's lots of different ways that are being, didn't have time to go into. But I think there is hope. Now, is it near-term hope or long-term hope? I don't know. But I can just assure you there's a huge effort being made to target prostate cancer with immunotherapy.
Okay. Thank you. Thank you.
You're very welcome.
Again, all these slides are going to be online and get recorded.
You can put a link in an email.
Yep, I'll do that too.
I just want to thank Nick for a great presentation. I know it's a lot of work to put it together.
Well, Eitan, I appreciate your being there because you asked all the right questions at the right time. To slow me down and to clarify the things that I wasn't making clear, so it made it much easier your being there. So thank you very much for that. And if there's particular interest in any subtopic of this group, of what I talked about, I'm happy to come back again another time and address those if people would find it helpful. Yeah, and I guess Jim will have the slide deck available. So, and if you have any questions that you think of, you can send them directly to me, or you can run them through Eitan and he'll send them to me, however you want to do it. But I'm happy to answer any questions.
Great. I just want to add one thing because this is now very clinically relevant. So, lo and behold, a couple of months ago, I had a biopsy, and Dr. Sedana at UC, and what has come back? The pathology report says, okay, Gleason grade 4 plus intraductal carcinoma. So Dr. Sedana, I thought out of the blue said, oh, you know what? Let's do a saliva test for germline mutations. Now, at the time I thought to just pull this out of thin air, but it turns out that this Dr. Antonarakis that Nick mentioned has managed to get the NCCN, the people who drive the guidelines for what is called clinical care, he has convinced them that now, if you have this intraductal carcinoma identified in your biopsy samples, you should be targeted for germline mutation testing. Because why? Because if it turns out that you have these MMR deficiency, these are mutations in the repair genes, in these DNA repair genes, then there is a correlation between intraductal carcinoma and these mutations. So if you have this intraductal carcinoma and these DNA repair mutations, that means that you could have what's called hypermutative cancer cells, which then can be present to the immune system in the way that Nick described. So you have very high mutation burden, which makes these cells more liable to be destroyed by the immune system. So although Dr. Sedana did not tell me so, he was actually doing what he's supposed to be doing. The NCCN guidelines are if you see intraductal carcinoma in your pathology report, you should be getting the germline testing. And if the germline testing is positive, they should also be doing somatic testing on your biopsy samples to see if in fact you have this hypermutated state in your tumors. And if you do have that, then you are a good candidate for immunotherapy. That is what Anton has just told me. I just came back from Johns Hopkins. So, thank you.
This was Sedona at UC that did this?
Yes, but any urologist should know about this because this is now standard of care. They should know about this. Doesn't mean they do, but they should. But that's why going to a teaching hospital is a little bit better. Those guys are a little more in tune to what's going on in the world. But Nick, thank you very, very much for a wonderful presentation.
An email to that portion of the care you just mentioned?
Sure, we can put on the website, we can set up an email.
Sure.
Yeah. Okay,
Great.
Nick?
Yeah, I just wanted to second Eitan's comment that these clinical trials are typically done at research centers, the Cleveland Clinic, for example, or lots. There's a medical school or a research department. You can typically try to find where. I mean, an academic research oncologist is going to know what's the latest going on in the field. So if you're going to go past standard of care, you know, your oncologist, most oncologists stop. They'll say, I've given you the standard of care, go to hospice. So getting to a clinical trial takes effort. And only an oncologist who's interested in science of treatment, who's looking at new therapies, who's interested in new therapies, they're the ones that can direct you to a trial, and then, of course, which ones are available in your area and where. But don't just rely on oncologists or other doctors to just know that last step. I mean, they'll just work through, you do this, when that stops, do that, when that stops, do that, and when that stops, go to hospice. That's how 90% of doctors work. So if you want to get on a clinical trial, you have to be active at that point.
That's right, and you can go to clinicaltrials.gov and plug in prostate cancer, and you get a whole, maybe 1,000 clinical trials out there for prostate cancer. There's a lot going on. So great. Of course, probably 90% of those are not going to be wonderfully effective, but some are. I mean, that's when enzalutamide became the standard of care, was through a clinical trial, and that one seems to work pretty well. So.
Right.
All right.
Well, thank you both.
It was my pleasure, and thank you for your patience.
All righty.
Okay.
Yeah.